think this is relevant because I know there's a lot of discussion about this particular letter from Chairman Waxman that was done on March the 20th. I think that was the day of the vote, or maybe the day before. Have you seen that letter?
I saw it at midnight on the Saturday before the vote. So
okay, and so this was addressed to a Texas congressman, but if basically, I think I'll just read from the letter. It says, I understand the Texas Health and Human Service Commission recently concluded the health reform would cost the state of Texas over $24 billion over the next 10 years. This projection is difficult to reconcile with the CBO with its March 18th, which in its March 18th estimate wrote, state spending on Medicaid and CHIP in the 2010-2019 period would increase by about $20 billion as a result of the coverage provisions. Now that's $20 billion for all 50 states. So all this spending would be in the years 2014 through 2019 after the state exchanges go up and the Medicaid expansions go into effect. Currently, Texas accounts for roughly 7% of the federal Medicaid spending nationally. If Texas accounts for the same proportion of federal Medicaid spending over this expansion period, its share of the total state cost of $20 billion over the next 10 years would be in the neighborhood of $1.4 billion, not $24 billion. This is such a glaring difference. Can you discuss that with it?
I will go through it, but I'm going to ask Dr. Allgaier and my staff to come up also, because his staff's done the analysis. A couple of things I want to point out. He's using a different time frame. He's not using the 14 through 19. I think he's actually using current year through whatever period of time. That's number one. Number two, he's not looking at administrative costs. The numbers that we've built in here have about an 8% administrative cost, and I think that's a low guess. By the way, their methodology on doing their estimates, they don't build in administrative costs. So you got a time period differential there. He's using a global that Texas represents 7% of the Medicaid population. Therefore, you should have 27% of the $20 billion. He fails to recognize we have 6.1 million uninsured. Massachusetts has, I think, 0.5% of their population uninsured. We have 25%. So you can't take national average statistics and apply it to state. I don't know where he went to school and got his math education, but it's not where I did. I'm sorry, I can't justify Congressman Waxman's math.
I think that the number that you know, and I don't know the answers to this. That's what we're trying to find out. But the number that I had particular questions about was the total cost to all of the states, all 50 states, for the 10-year period would be $20 billion, and that was the number that struck me. Can you comment on that? Is that an accurate projection?
I would say, Senator, time will prove the accuracy of the number. And I will see that the congressional budget number of $20 billion will move up as time moves through. My staff, actually, our numbers are based upon the Congressional Budget Office's methodology. Where we differ is administrative costs and time. We've duplicated everything we did. We've got their data, analysis that you can globally, and applied it to Texas. Our numbers are fairly consistent for the same time frame and deal with admin factor. And now we did not put in this set of numbers today the dish number, because that was one of the controversial things. So I just pulled it out and said, we'll argue through that. And as we peel through this thing, my numbers are going to go up. I guarantee you it's going to go up, not down. Well, so I can't rationalize Congressional Budget Office numbers, nor I can Congressman Waxman's application of 7% overall, when I know that I got more population uninsured than most states have total population.
But you're.
I think your testimony was that we have 6.1 million uninsured in Texas. Under the federal plan, we'll pick up 4.5 million new insured. Would have 1.6 million that are non-citizens that would continue to not be insured. Can you break out the 4.5 million by program?
Of the 4.5, 2.1 will be Medicaid, which is what that chart 4 represents. The other will be out in the private insurance market, either paid by the individual or paid by the employer, is my best understanding of the number.
Okay.
Commissioner, could you pull your mic a little closer when you speak?
Sorry, my voice is also fading.
And on chart on page 6, as we're looking at these costs, I count up of your $27 billion cost out to 2023. I pick up 23 billion of that from 2017 to 2023. Is that accurate?
What chart you working on?
Page 6, your total cost, year by year estimate.
Yes. That's probably pretty accurate.
What was your question?
My question is, we're being presented with a sticker shock number, 27 billion. That's being brought to this committee to say this is what this change will impact state GR to 2023. As I look at your chart, really 23 billion of that is from 2017 to 2023. Is that right?
Correct.
And that's based primarily on assumptions that have to do with the additional cost related to the expected reauthorization of CHIP without the super FMAP and the reduction to 90% in perpetuity. Those are the key assumptions that are driving that number.
Absolutely. And the rate increase is driving part of the number also, and maintaining that rate increase beyond the 100% federal matching funds, which is only in 13-14. Now, one of the last bullets, and I think this is another one I want to emphasize, I think there's some policy decisions around this probably not need to be made to 2011. First one being is you have a large amount of funding through multiple different sources that cover uncompensated care throughout the state. You have trauma funds, you've appropriated tobacco receipts, supplement receipts, you have the county indigent health care program, you have multiple programs at the Department of State Health Service that the dynamics of those programs all change when individuals have insurance. Things such as kidney health, your HIV program, your children with special health care needs, primary health care program, all those programs were focused on people who were underinsured or uninsured, underinsured or uninsured, now will have insurance. So it's going to change the dynamics of what we come in and ask the state to fund for those programs, because you will have insurance. These may be an area where there's some fiscal savings. There may be some savings that we have not reflected in the previous numbers, and I don't know what those are yet as we work through those areas. So that's kind of a major issue to talk about.